Nurse Nia here, and welcome back to the break room. Did you miss me? So today we're actually going to shake things up, and I'm going to have a story time. I'm going to tell you how my team and I, or what interventions my team and I took to save a patient's life, okay? So just a little background. My patient's diagnosis was dyspnea. So he was having a hard time breathing. He was having trouble breathing, and he had a history of CHF, hypertension, and COPD, okay? So COPD is chronic obstructive pulmonary disease, and CHF is congestive heart failure. So basically, my patient is up for discharge, and before you discharge any patient that's there for dyspnea, you basically have to walk them around the unit and make sure they're able to maintain a good oxygen saturation before they're able to be discharged. So this day in particular, I walk into my patient's room and I let him know we're about to go for a walk. You know, we have to make sure that you're able to maintain your oxygen saturation before you go. So my patient hops right up off of the stretcher. He's ready to go. I say, stop. Let's get your oxygen on. Let's go get the oxygen tank. I'll be right back. He insists he doesn't need it. So basically at this point, my patient is refusing oxygen. Patient always has the right to refuse. So he insists he doesn't need the oxygen, so we start our walk. About midway down the hallway, I feel somebody grab onto my arm. He's clutching me. I look over at my patient. He's sweating profusely. So we call this diaphoresis. My patient's diaphoretic. His eyes are bulging out at me like this. So instantly I know my patient is in distress. Both of these are signs of distress. Put my patient in a chair, run him back to the room. My tech comes in, asks me if I need assistance. We try to grab him and place him on the stretcher. At this point, he's dead weight, okay? We cannot pick him up. Help! Help! That's the first thing you do in any resuscitation effort. Call for help, okay? You need everyone in the room, everyone to play their role. So at this point, everybody comes running in the room. We finally get my patient back onto the stretcher. Our first try was the non-rebreather mask, okay? So we tried the non-rebreather. This mask delivers up to 15 liters of oxygen. We slap it on him. We're not getting any results on the monitor. We still don't see any respirations. We check again. My patient has no respirations. We check 3 different sites for a pulse. My patient has no pulse, okay? My patient is down, code blue at this point. Code blue, no respirations, no pulse. Start CPR, okay? If you don't do anything else in this situation, start CPR. You hear no respirations, no pulse, go straight into compressions, okay? Grab the bag valve mask. Someone needs to be doing rescue breaths while you are doing compressions. When you're doing your compressions, you have your arms locked, hands enclosed, sternum, okay? So we're doing compressions. We maybe do 2 rounds of compressions. We place the pads on my patient, okay? And then we're pushing epinephrine. So the idea behind epinephrine, we're trying to kickstart the heart, jumpstart the heart. So we push epi once, no result. We push epi twice, no results. We pause compressions, we check for a pulse. My patient has a pulse, okay? During our CPR efforts, while the nurses are doing CPR, MD is at the head of the bed intubating the patient. So MD is dropping a plastic tube down the trachea to hold the airway open, all right? So at this point, patient is intubated, respiratory therapist comes and she gets him connected to a vent. The ventilator is a machine that breathes for you if you cannot breathe on your own. So at this point, there's another nurse working on an IV access. We only have one access at the time. He had a 20 gauge on his right AC. We slap another 20 gauge into his left AC. Now that the patient is intubated, we have a pulse again, which is called return of spontaneous circulation. ROSC is what we call in the hospital. We are checking vital signs, okay? We're checking to see what the pulse rate is. We're checking what the respiration is. We're checking for blood pressure. We were unable to obtain a blood pressure from the monitor, okay? So anytime you can't get a blood pressure from the monitor, manual. We're taking it back to nursing school, okay? So you better know how to take a manual blood pressure. We try for a manual blood pressure. I hear maybe 79 over 52. Another nurse hears 79 over 34, I believe. Not good pressure. Hey doc, this is where your recommendation comes in. Maybe we should start an ART line. An ART line is an arterial line, obviously it's placed in the artery, and it's gonna give you a continuous blood pressure reading. So doc is working on the ART line. We are still working on pressures. We have 2 IV accesses. Patient has a history of CHF, so the fluid, you kind of want to be eerie about how much fluid you place, even though we know that the blood pressure is pretty low at this point. So we go ahead and hang LR. So lactated ringers, we have LR going just for blood pressure support until we get the art line in. The art line is placed. We see that the pressure is still low. That's where pharmacy comes in, okay? Pharmacist recommends we do norepinephrine or Levophed. Norepinephrine is Levophed, same drug, okay? So norepinephrine, the thing about that, you have to know your patient's weight. Know your patient, okay? If you do not know your patient's weight, it is dangerous to run norepinephrine. It is mics per kilograms per minute. So we run norepinephrine. It's not really touching my patient. Pressure's not rising the way we want it to. So we call for vasopressin. Vasopressin is another IV drip, but you do not titrate vasopressin, okay? Most hospitals is 0.03 units per minute, if I'm not mistaken. 0.03 units per minute. And vasopressin, the idea behind that is the veins. It'll get the veins to constrict by there sending the pressure up. So at this point, we still have the pads on our patients. We still have a pulse. We still have respirations, but blood pressure is still low. After we hang the vasopressin, blood pressure comes back up. We have a good pressure. We have good mean arterial pressure. MAP. MAP's telling you patient still has brain activity, okay? So we have good pressure. We have good MAP. Let's take it back to intubation. Anytime you have a plastic tube down your throat, naturally you're going to fight it. That's not normal for you. So our intubation drugs, we use succinylcholine, which we call sucks in the hospital, and we also use propofol. Succinylcholine, let's talk about succinylcholine. Succinylcholine is a paralytic. It's going to relax the muscles, thereby keeping the airway open, okay? So it's helping the vent do its job. It's helping the vent breathe for the patient, okay? As long as the patient's not fighting the vent, it's going to help the patient relax. Propofol, also known as the drug that killed Michael Jackson, is anesthetic. Propofol is an anesthetic, and it basically is going to relax you so you are not pulling at your tubes, your lines, and your cords. None of this is normal to you. You wake up with a lot of tubes, lines, and cords, you're naturally going to pull at them, okay? You're confused. So in this case, I used my best nursing judgment, and I did not use the propofol. Propofol will drop your blood pressure, and as we discussed, my patient was not able to maintain a good pressure, so stayed away from the propofol, okay? Next, we're going to causes. What could have caused my patient to rapidly deset like this? So we're doing our assessment. We're going to go back and do an EKG. EKG records the electrical activity of the heart. You want to make sure your patient is in sinus rhythm. As discussed before, my patient still had pads on. If he deviates from sinus rhythm at all, we have the pads there, we're going to defibrillate, okay? Patient is still in sinus rhythm. Doc's thinking it might be a PE. So we go over to CT. We get a CAT scan of the chest, make sure that there's no clots there. Next is our transfer to ICU. Time is not on your side, okay? Make sure you have a portable monitor. Make sure that someone escorts you with your patient up to the ICU, just in case you have to code the patient again. Keep the pads on the patient, okay? Rapid. Everything is rapid. You're running up to ICU. You drop the patient off the ICU. When you get back down to your unit, your first action should be to cover yourself. Go in and make a detailed note. Go back and look at your code sheet. Look at everything that your recorder wrote down, okay? Your verbiage is very important in your note. I immediately noticed my patient was hypoxic. I immediately called for help. I immediately got my patient on the stretcher. I immediately applied the non-rebreather mask, okay? These are the things that are gonna protect your license, all right? So, all's well that ends well. We got our patient back. We did save a life, but I'm gonna leave you with this. Cover your license, cover your livelihood. All right, that's all I have for you all today. See you next time on In the Break Room with Nurse Nia.